Good evening, all the aspirants present here. Good evening, all the doctors present here. So
Yeah.
today's topic is case-based discussion on RTA polytrauma. And the moderator that we have here is Dr. Sanjeev Kumar sir. He is a professor and HOD Depth of Critical Care Medicine at Indira Gandhi Institute of Medical Science, Patna. We have examiners, Dr. Ritu Singh, ma'am. She is Associate Professor, Department of Critical Care Medicine at IGIMS Patna. Also, we have Dr. Akhilesh sir. He is a HOD Depth of Critical Care Workout Hospital, Mumbai. And here we have the case presenter, Dr. Abhishek Kumar Srivastava. He is a DM Critical Care Medicine resident at IGIMS Patna. Sir, you can take over. Thank you.
Thank you, Fatma ma'am, for the introduction. Good evening, everyone. My professor, Dr. Sanjeev Kumar, Dr. Ritu ma'am, Dr. Akhilesh sir, Dr. Gunadhar Padhi sir, and Dr. Asif Iqbal sir. Today, I'm going to present a case on RTA with polytrauma. So the case goes like so. This is a 27-year-old male, factory worker by occupation, and resident of Siwan, Bihar. He arrived in going through according to ATLS guideline. He arrived in an ambulance. He was collared and backboarded. And mechanism of injury was fall from 11 feet height and landing on his feet first and then on his back. On the scene finding, there is no history of loss of consciousness, seizure, or vomiting. Now, coming to the primary survey that was done, airway with cervical spine protection. Airway was patent, patient was conscious and speaking clearly. He could just say, speak out his name and all. Cervical spine tenderness was present. In breathing and ventilation, respiratory rate was 18 breaths per minute. There was symmetrical chest expansion on visual inspection. So there was no pneumothorax and hemothorax as of then. In circulation, patient's BP was 130 over 80 with 80 pulse was 80 beats per minute. No signs of external hemorrhage and skin was warm. Moving on to disability, the GCS was 15 out of 15, alert and oriented. Patient had quadriplegia, PAR was 1 by 5 in bilateral upper limb and 0 by 5 in bilateral lower limb. And there was sensory loss below the nipple line, that is at T4 level. In exposure and environmental control, the patient had a scalp laceration, scalp tenderness, and his temperature was normal. That was 98.6 degree Fahrenheit. Now coming to the secondary survey, as per AMPLE guidelines, there was no allergies, none reported. Patient was not on any medication, no prior history of hypertension, diabetes, or prior trauma. Last meal was not specified, and environment. So mechanism was fall from height. Symptom were left lower limb pain with quadriplegia and inability to pass urine. And environment was, it was a factory site accident, and then the patient was transferred to the ICU. In secondary survey on physical examination, a general patient was conscious, alert, vital sign was pulse was 80 beats per minute, BP was 130 over 80, respiratory rate 18 breaths per minute, and temperature was normal. Excuse me, sir.
Yes, continue.
Okay, sir. Sorry. And in head and neck examination, scalp laceration was present. No basal skull fracture sign were present. Chest was symmetrical in expansion. Normal breath and heart sound were present. In abdomen was soft and non-tender. Musculoskeletal, left lower limb pain was there. Quadriplegia was there. Cervical tenderness was present. In neurological, patient was alert. Cranial nerves intact. Quadriplegia was present in motor. Sensory loss below the nipple line. Reflexes were normal and the anal tone was preserved. Hello, sir.
Is there any disturbance in network?
No, sir. It's fine. It's completely fine.
Okay, Abhishek, continue.
Okay, sir. So now, what all investigation we did? On the arrival of patient, I did a E-fast in ICU. It turned out to be negative. And we went with the NCCT head and whole spine as the nexus was positive. Patients had a cervical, posterior cervical spine tenderness. And as per Canadian C spine also, patient had dangerous mechanism of injury. Fall was from more than 3 feet. MRI spine was done to evaluate the spinal cord injury. Chest X-ray was done. X-ray of left lower lip, AP and lateral view was taken. In laboratory examination, complete blood count was done. Hemoglobin was 12, TLC was 7,500, platelet count was 1.4 lakh. ABG was normal, pH was 7.3, PCO2 of 36, PO2 of 180, and a lactate of 1.4. Electrolytes, renal function test, liver function test, PTINR, all were normal. Urine analysis was sent to assess the bladder function. We did sequential multiple laboratory examination. And in other signs, we had continuous vital sign monitoring with periodic neurological assessment and periodic e-fast examination. Now, this is the MRI of his spine that revealed patient has a C5 body fracture with retrolesthesis with spinal cord injury. I hope this is visible to all. Shall I move?
Yes, it is visible.
There is also some indentation of the T3, T4 level.
Yes, a little bit of compression is seen there.
Yeah. Okay, move.
So this is the X-ray of left lower limb. And here we can see the fracture of shaft of femur. Now, this was the NCCT head that was done. It turned out to be normal. This was normal. There was no drop in consciousness throughout the hospital stay whatsoever. And in Asia charts, the first thing that we can see here is that T4 level patient had a sensory loss of T4 level, and the neurological level of injury was C4. And patient was unable to move. Patient was not having any motor power whatsoever, but his anal tone was present. So we graded him in Asia C, that is motor incomplete. Now, immediate management, cervical spine. For cervical spine, we took Philadelphia collar was already applied. IV access was taken and 500 ml bolus fluid IV was given. Foley's catheter was inserted. Neurosurgery and orthopedic consultation was sent. Patient was started on antibiotic and other supportive treatment. And we started on injection methyl prednisolone 1 gram IV OD for 3 days, suspecting spinal cord injury as his sensory level was ascending. That's why we started the patient on methyl prednisolone. Now, for definitive management, for cervical spine, C3, C7 fixation and decompression was done on day 6. For fractured shaft of femur, close reduction with internal fixation and intermedullary nailing was done on day 11. Further course of patient, gradually the patient power increased to 3/5 in bilateral upper limb, while in lower limb, it was still 1/5. The sensory level that was initially T4 and was ascending up, after that, it descended till L1. He could feel the touch and temperature till L1 level. So patient was discharged from the ICU with Foley's in situ in hemodynamic stable condition. And for further follow-up, we are calling the patient after 1 month to evaluate the power, sensory level, and to remove the Foley's if the patient is able to self-vault. So advice on discharge, what we gave to the patient was urinary catheterization for retention, lactulose just for constipation, nutritional support, early physiotherapy, air mattress for pressure source, and monitoring for infection and pressure source. This is the X-ray that is showing post-cervical spine fixation that was done from C3 to C7. This is the post CRIF and IMNIL for shaft of fracture left side. So this was the case that we got in our ICU and I presented. So any questions? And
Thank you, Dr. Abhishek, for nice presentation. Now session is open for discussion. If any query, they can ask.
Ritu ma'am, you can start question.
Hello.
I'll start.
Yeah.
So this is a case of polytrauma, but mainly it is spinal cord injury.
yes, ma'am, mostly.
So can you just describe your Asia chart, because that was not much visible to me.
Okay, ma'am. So this is my Asia chart. And as per this, the sensory level was till T4. The neurological level of injury was C4. And the PAR there was no PAR in upper limb and lower limb, but the anal tone was preserved. That's why our patient was categorized as Asia category 3, that is motor incomplete.
Okay. So this was done before, this should have been part of your examination, or was this done after your investigation? MRI,
No,
because
ma'am.
MRI you showed before, and so this is more of a clinical thing.
Yes, ma'am. This was done on the day of arrival of the patient, ma'am.
Okay, so this corroborated with your MRI finding.
Yes, ma'am.
So sensory was complete and incomplete.
Sir, question is not audible.
Whether patient has sensory incomplete or complete.
Sir, sensory loss was incomplete only because
It's been partial.
Yes.
Hmm.
So the sensory level was intact below T4.
And below that,
Above that, patient had complete sensory loss, and below that,
above,
sorry.
below that, no. Below
Yes, sir.
that sensory loss.
Below. Yes, sir. Sorry. Below
Hmm.
T4 level, patient had complete sensory loss.
So if
And
patient has the complete sensory loss and the motor is so according to this it will come under Asia B if the sacral sparing is present.
sir, but here the patient also had voluntary anal contraction.
But sensory, what is the condition of sensory? Sensory is the complete loss below the T4.
Yes, sir. Sensory was complete loss below T4 level.
So according to this, it could come under the ACRB anyway. So is there any role of the methylprednisolone?
Yes, sir. Since we suspected spinal cord injury as his sensory level was ascending upward, like it was T4, then it ascended. The patient had loss of sensation on his elbow also after 1 or 2 days. So we suspected spinal cord edema. That's why we gave methylprednisolone 1 gram for 3 days before any substantial complete management, that was fixation of spinal cord.
So after giving it gradually improved.
Yes, after giving methylprednisolone, his sensory loss levels stopped ascending, and further after definitive management, it came till L1. Patient had complete sensory to touch and temperature till L1 level, sir.
There are few questions in the chat box. What is why both surgeries were not done in the same time? DVT prophylaxis. That was, I think, more of a logistic issue rather than something to do with the management. Ideally, it should have been done in the same sitting, both the surgeries.
We actually advocated it to do them under the same anesthesia, same general anesthesia, but somehow we couldn't manage the logistic, so it was done on the separate days.
Okay. So what is the current evidence for role of steroid in spinal cord injury?
Ma'am, as such, there is not, it doesn't fall in class 1 indication, but still in post-surgery and all, neurosurgery people do give it.
It is the
Okay, so there's
convention,
one more question of steroid. Why steroid dose is so low for your case? So actually loading was given earlier in a previous hospital. So that is why it was maintenance was taken. But yes, you rightly said that currently in view of more infection, stabilization early is more important rather than giving early steroid. And if it has to be given, it should be given early in the first 12 to 24 hours.
First,
Yeah. So there's one more question, I think. What is the role of antibiotic therapy, early antibiotic therapy?
Ma'am, early antibiotic therapy was just given, just we took a broad spectrum antibiotic just to cover the gram-negative organism and all, and we never gave gram-positive till the day of surgery. So more of prophylactic only, what I'll say, because that was not based on culture and all. And since patient also had a fracture of left lower limb, so we thought we might give the
So
antibiotic.
was it an open fracture or a closed wound?
It was a closed.
So another question is why steroid dose is so low, especially Ora-Dexon, that is Dexona per kg, or if patients come within the
Sir, we've
4
answered
hours.
that question. We've
Yeah,
answered
yeah.
कि अभी कोई
Yeah.
रोल नहीं है. Early का ही
Mhm.
role है. Otherwise, it is not indicated in view of any infection.
Okay, okay.
And dose should be 1 mg per kg only.
Yes. And DBT prophylaxis was given, sir. Actually, now I'm seeing the question. And we had taken DBT prophylaxis. Once we ruled out bleeding and all the investigation came, we had taken the DBT prophylaxis, and that was stopped before surgery. And after that, we started him again on Clexane after 48 hours of surgery, sir.
And counseling of the family is a very difficult task. And I think it's really very challenging to any family. How will counsel this patient?
Sir, actually, this is quite challenging as from family perspective and all. So we need to tell them exactly about the patient situation and how the patient is going to turn up in next few months and what all intervention you can do to fasten the recovery. So for that, role of physiotherapy, preventing any bed sore, preventing any further infection, since the urinary catheter was in situ because the patient was unable to avoid the urine. These all things were told to patient attendant thoroughly. And we had a counseling session with senior consultants and all. So the family was quite convinced, okay, that they'll take good care of them. That was that whatever advice we had given on the discharge slip with advice for regular follow-up.
Any questions from audience? A spinal cord injury is a very difficult thing to manage, and especially for the patient, it is a disastrous thing. So I think each and every person should know about detail about all the thing. So is there any sympathetic overstimulation sign
No,
in this
sir.
patient?
No, sir. We didn't get any sympathetic or full stimulation sign. During the early course of the patient injury, patient was having bradycardia. His heart at the time of admission, ma'am.
Mm.
But after that, his heart rate gradually became normal, and he was discharged at a heart rate of around 70 per minute, while earlier heart rate was in the range of 40 to 45 per minute.
Is there any spasticity, jerky movement in the leg?
Sir, now the power only is 1/5, and he's not able to move. He was not able to move his left lower limb because of surgery. So the power from 0/5 it had increased to 1/5.
What precautions you have taken for the preventing bed sore?
Sir, for bed sore, one thing which we do is providing air mattresses to all the patient who are supposed to be immobile for a long time. Second thing is we change position every, not in this case, of course. So in this case, basically, we just had provided air mattress for this patient, sir.
And
Because change.
after long time laying down, patients have some problem when we just make them sit. So for that, there is a need of the adaptations. How will adapt all these things?
Sir, actually, he will need support of physiotherapist and family member to actually change his position from lying to sitting. That's where the family role comes into play.
No,
And
no,
more,
but for that there is a need of the rehab people, and then gradually it's a need to incline the patient to made gradually uh, uh, moving up, so that he can adapt the situation, and it will take about the month of the time
yes,
to a standing position.
yes, sir.
So it's not easy task. So it's the total work of the rehab people, and until unless the rehab people are work hard, it's very difficult to manage all this thing. Patient see whenever the patient wake up and try to just sit or even the stand, and suddenly they feel the giddiness, hypotension. So that for that it's gradually increasing the angle of the. Okay. I think most of the audience are very quiet. Hello?
I'll answer these questions. So, as far as our GCS of patient, I had told that GCS was E4, V5, M6 throughout the hospital stay. Specific time for spine fixation. Sir, it should be done as early as possible once the logistic has been arranged and provided there is no evidence of infection like in this case. So it should be done as early as possible. And cauda equina syndrome is an emergency actually. If the trauma is below making it cauda equina syndrome, then this patient has to be posted for emergency surgery. If patient develops cauda equina syndrome.
Uh, Kindly again summarize the ASIA chart. One person such requested. Dr.
Yes, sir. So Asia chart basically is American Society for Spine Injury Association, Spine Injury Association, and it will class it takes into consideration three factors. One is level of myotome involved, one is level of dermatome involved, and one is the level of your anal canal, your level of anal canal. According to after this, so it is actually recommended to fill the Asia chart daily so that we can monitor the progress of patient and of course to rule out if there is spinal cord edema developing or not. And according to that, we'll classify the patient into Asia Impairment Scale, AIS, in which A is complete, no sensory or motor function is present in the sacral segment of S4 and S5. B sensory incomplete, sensory but not motor function is preserved below the neurological level of injury and includes the sacral segment S4 and S5. And like in our patient, C is motor incomplete. Motor function is preserved at the most caudal sacral segment for voluntary anal contraction. Then there is motor incomplete type D. Motor incomplete is defined as C plus there is loss of muscle function below the single neurological level of injury, having a muscle grade more than 3. Then E is normal if sensation and motor function are tested and graded as normal in all these segments. So these all information we deduce from the Asia chart, sir. So
Another question is Foley's catheter. How much time in this type of
Actually,
catheter?
somebody also asked about autonomic dysreflexia. So yes, that can be exaggerated by your surgery, but you need to identify that it is something like in the brain, जो PSH होता है, there is triggers in this, and there is dysregulated autonomic response. Maybe bladder bowel care is very important. तो जब तक ऑटोनॉमिक डिसरिफ्लेक्सिया रहेगा फोलीज वगैरह तो रखना पड़ेगा. So both the questions can be answered together.
What are the factors which aggravate the autonomic dysreflexia?
Sir,
So
the
Oh,
Abhishek, you
please.
can tell.
Ma'am, जैसे cervical spinal patient है cervical spinal, so any change in position or especially movement of neck and all will trigger autonomic dysreflexia in this patient. And second
Bladder
thing is
distension, bowel
bladder
distension
no,
also
no, no,
can
distension.
no,
be
no,
Yes,
that.
no.
ma'am.
Only,
Bladder.
only three things you have to remember: bladder, bowel,
Bowel.
uh, and in growing nose. Any injury below the level of the injury, and for that it's important, especially in which level it's occur.
Yes,
At
sir.
what level it's occur? Patients of the usually at the level of the T6. If injury is above the T6, in that case only autonomic dysreflexia usually found.
Yes, sir.
Okay, so only these three important thing, that any in any injury, any continuous pinching, yeah, continuous ingrowing nail like that can irritate, and that may cause otherwise apart from this distended bladder or distended bowel, if all this causes the autonomic dysreflexia.
Yes. Yes. If
So for
you
that
permit, I'll go to this question. If in case of RTA patient has helmet on, how to go ahead with airway management? It is actually a good question. See, in this case, what we'll do, we need 2% technique in this. One person will stabilize the neck and spine, and the other person will release the chin strap, and then he will remove the helmet while the first person is maintaining that is can be called as Mills manual inline stabilization of spine.
Yes.
Sir, DVT prophylaxis choice will be Clexane, low molecular weight heparin.
Enoxaparin. You should tell
Yes,
enoxaparin.
yes, sir. Okay.
Hmm.
In this case,
So,
sir, steroid was given for 3 days, sir.
so why there is immobility of the limbs? So steroid should be continuing for a long time. No, no,
Sorry.
steroid is given. How long you have given the prophylaxis?
DVT
For
prophylaxis.
DVT prophylaxis will continue, sir, till the person is not able to, till the person is able to have full range of movement in his limb. Because once the surgery is done, we started him on enoxaparin after 48 hours,
Or
after excluding bleed and all.
or full range of the physiotherapy just started.
Yes,
If
sir.
DVT is yeah. So that is the important thing. And Foley's catheter you have to keep, I think, until his own function
He
is
is
not
able to
recovered.
avoid the, yes.
Most of the time, a long duration of the catheterization is kept. Otherwise, some patients require SPC. So that is the thing. And nutrition's when you should start and how.
As early as possible. Nutrition should be started as early as possible, and patient was taking enteral feed. So we started as per latest guideline, and when we started him first on trophic feed, later one day after we started him on full feed, as patient was not having significant GRV, that is gastric residual volume and all, and along with perinorm prokinetic agent, we started him on full feed. So.
Dr. Mohammed has raised his hand.
Yes, thank you, ma'am. This is a clean-cut case of spinal cord injury. Most of the times we get it if there is a rib injury, if there is pneumothorax. What will be the ventilator management? Sometimes, if the patient comes with spinal cord injury with hemothorax, with after 6 to 12 hours, it develops ARDS. Then at that moment it's very difficult for us to set the ventilator management. What about the ventilator management? This is my first question. And the second question is, if there is a if the spinal cord injury is clear cut, then most of the times if the GI movement is absent. For that reason, the if we start NG tube feeding, the all the materials come back. After the in that complication, what we have to do it? Number two question. Thank you.
Okay, sir. So first, I'd like to go one by one. So in case of RT and all, patient can have a spontaneous pneumothorax, would could be small, and we could miss it on the first day, but it could later develop into tension pneumothorax, and if hemothorax present as well. So first of all, our management would be ICD tube insertion if it is tension pneumothorax or there is massive hemothorax. And moving on to ventilatory management. See, obviously, in this case, if ARDS set in, we will go with normal ARDS protocol. But here, proning won't be done till the patient has cervical spine stabilization. So that means low tidal volume of around 4 to 6 ml per kg body weight, titration of FiO2 as per PO2 to maintain a level of 60 of Hg. And hello.
So Dr.
Hello.
Gunadhar sir has also joined us right now. Dr. Gunadhar sir, are you there?
Hello, Dr. Gunadhar.
Hello, so uh,
Okay. Proceed.
I would like to answer the second part of question that was on if patient is not accepting enteral feed. Obviously, then after 48 to 72 hours, we'll start him on total parenteral nutrition. And after that, we'll keep trying for the enteral feed. We'll find a window to start enteral feed. And we'll start it as soon as possible with continuation of total parental feed or converting it to only partial parental feed.
பாத்தீங்களா சார் ஐசிடி போட்டு வீட்டு அது சொல்றதுக்கு எவ்வளவு நேரம் ஆகும்?
Dr. Ravi, you had some question?
Please unmute.
Yes, ma'am. Dr. Abhishek, what are the indication of surgery in that patient?
Sir, surgery or indication for surgery was one is called edema that we suspected. And second, the MRI had a retrolisthesis. So we went with the spine fixation. That was the definitive management of choice.
But patient has weakness in this condition, in this case.
Sorry, sir?
So patient has weakness in this case.
Yes, sir.
So only steroid you are given or any neurosurgery intervention?
So
Actually,
we went
Dr. Ravi has joined late. Already explained that patient was operated and fixation was done.
Sir, actually, there was some network connection because of that. Few slides I have missed.
I will just
yes.
So,
Yeah.
one second, sir.
Excellent. Please
Yes,
explain, Abhishek.
Okay, thank you.
The definitive management was cervical spine here. The fixation was done. And decompression, C3 to C7 fixation, and decompression was done on day 6 of injury, sir.
Dr. Gunadhar? Dr. Gunadhar, please unmute yourself. Please not here. So I think most of the questions you have cord edema with the quadriplegia, why was so much delay in the doing the surgery? That is the some logistic issue, I think.
And there was one question on driving force. I think the question was driving pressure. So, like sir had asked if in ARDS, obviously driving pressure should be kept low because low driving pressure is associated with better outcome of the patient. So it will be not that we'll keep on increasing PEEP and all will titrate to optimum PEEP so that we get a optimum driving pressure that is low enough to prevent further ventilator-associated lung injury. That is quite common in ARDS.
Would it help I was do surgery early? So I think surgery was done as early as possible because
Yes, sir.
yeah, Abhishek?
Yes, sir. Surgery was actually we had sent the neurosurgery call on the first day itself, and we actually we had due to some logistic issue because MRI was planned and this thing they had asked for MRI and all. So the surgery took some time. Otherwise, we would have advocated to take the surgery as early as possible because patient was not having any active infection or nothing. So definitive management should have been done a bit earlier.
Dr. Anup is also connected. Anup? Dr. Anup,
Yes, sir.
how are you?
Hi,
Why
sir.
you are so silent?
I am on duty, sir, right now. I am in ICU. That's just case.
Okay, so Dr. Abhishek has just presented. I think perhaps you have heard.
Yes, sir. We will presented case,
Oh,
sir, and we will manage.
So is there any further questions?
No, sir.
Okay.
I'll just answer this last question. Okay, generally that it is 5 days, but since the spinal cord edema subsided and we were worried if further patient develops infection and all, and there was no this thing proper class 1 evidence for methylprednisolone, so we gave him for 3 days. Then we went for definitive management. So that's why in this case we gave steroid for 3 days.
Dr. Asif? Dr. Gunadhar? I think most of the questions we have already discussed. Someone, yeah.
If we have any more questions, any student have any question they can ask? So we have got one more question. Ideal dose and duration of steroid in spinal cord injury.
Ma'am, that I just answered.
Okay.
Because
So I
obviously
think
there's no.
we should wind up this session here. Shall we, sir?
Okay.
Thank you, sir.
No,
It
there
was
is one. There is one more question. Actually, I'm sorry to interrupt. There is one more question. Type for developing neurogenic pulmonary edema in spinal cord injury. So very sorry, I'm unaware of, and I would like if my seniors, like Dr. Sir, Dr. Anup, Ritu ma'am, or anyone can throw some light on this. The last question, please.
So, neurogenic pulmonary edema. So, what do you mean by neurogenic pulmonary edema? It's due to the spinal cord injury. Dr. Ritu? Yes. So, I think there is. We are not aware that any hard time, but if a cervical cord injury is old age, there is any role of the steroid? Definitely no role.
No rules in that. Yes, sir.
Even initial phase, the role of the steroid is also controversial, because most of the studies shows that it has the equivocal result. But in convention, people are using, and someone also get benefit. But overall, in long duration of the study, it was found no benefit. But still, people are using.
Neurogenic pulmonary edema. It will be similar to ARDS. Management will be like ARDS only, but I don't have a specific timeline for it, sir. Very sorry for that.
Dr. Gunadhar, please unmute yourself. Dr. Gunadhar has managed the cervical cord injury of my son
Okay.
at Apollo, Navi Mumbai. He's a very dedicated person. So I know very well how patients feel and how it's going to manage. Anyway, if no further questions, we should wind up.
So I believe there are no more questions now.
Yeah.
And thank you, Abhishek sir. It was really a nice presentation. Thank you, Sanjeev sir. Thank you, Ritu ma'am. And on Thursdays, we are going to have more case-based session. I would request all the participants to kindly join the session. Thank you.
Thank you so
Okay,
much.
where is Dr. Asif?
Sir, actually, he got a.
Okay.
Sir, actually, he was in the meeting, but he have to leave because he got an emergency in the hospital, actually. That's why.
Okay. Say hello to us.
Thank you,
Okay.
sir.
Okay, thank you everyone for providing me with this opportunity. Thank you.
Okay.
Have a very pleasant evening. Thank you, sir.
Okay.
Bye.
Okay. Thank you, everyone.
Thank you.